Strength and Chiro podcast. This is season 3. At the very top left here, we have Luke Gashard. You can call him Luke Gashard, one word. Dr. Luke Gashard, welcome to your own podcast.
Yes, Bryce, good to be back for another episode.
Following that up, I want to introduce Stephen Redmond. Some call him Redmond, I call him Redmond. It's either or. Welcome to your own podcast, Dr. Stephen Redmond.
Thank you so much. Happy to be here.
Can we get a dog cam? Give us an update.
Yes, he is on the floor this time.
Oh.
He's still alive, I promise.
But yeah, hey, we are excited to have an amazing guest on the podcast. Dr. Shiloh Heesch, welcome to the podcast.
Happy to be here.
It's great to have you here, and obviously we've got lots of questions. But before we jump into some questions, would you like to give us a short rundown of who you are, where you come from, what you do, etc.?
Yeah, so I'm actually an expert at making short stories long, so please feel free to cut me off whenever you guys need to. But so I'm Shiloh Heesch. I'm a chiropractor currently located in Eagan, Minnesota, which is just a suburb of St. Paul, Minnesota. I'm originally from South Dakota, so I'm one of about the 7 people that come from that state in the upper Midwest in the U.S. Grew up on a farm. I have 2 older sisters, my parents, and we grew up raising cattle. My dad is a grain farmer, so corn, wheat, soybeans, and sunflowers. Found out very quickly in my life that the farm life was not something I was remotely interested in. When I was about 8 years old, I started going to a basketball camp in my hometown, and I was like, ooh, sports, that's pretty fun. So I quickly deterred from the farm life and decided that I kind of wanted to do something in the sports realm. I graduated high school with 19 kids because that's how rural we were. Just, nobody in the area. Pretty much either your parents were farmers or teachers, and they were just teachers at the school. And then, that's kind of how things work. So I grew up as a 3-sport athlete playing football, basketball, and then ran track in school as well. I would not say that I was necessarily good at any of those things, but when you are 6'3" in a town of 400 people, it's kind of assumed you play sports. And we had a pretty good sports program for being a really small school. Went on to get my undergrad in another small school in South Dakota, where I played college football for a year. Learned pretty quickly that there's a big difference between college football and high school football, regardless of what level you play of college football. I was heavily kind of pursuing the chiro PT route through undergrad. And then kind of just decided once I visited Northwestern Health Sciences University here in the Twin Cities, I met Dr. Tim Stark, who I'm sure I'll talk about plenty later on, who is a pretty well-renowned sports chiro. Had a conversation with him, and I was like, I don't know what else this place is like, but if he's here, I'm here, kind of thing. And so after I graduated undergrad in 2017, I started here at Northwestern, graduated from chiropractic school in 2021, moved back to South Dakota for a year where I got to work in a clinic in Sioux Falls, and then got to work with a NBA G League team. So like the developmental league is located in Sioux Falls. Got to work with their team for a season, and then some tackle women's football. And then I suppose 2 years ago now, I returned to the Twin Cities to my current role, which is a sports chiropractic resident at our Human Performance Center at Northwestern Health Sciences University. And so I've been there for 2 years, and actually just recently this spring bought a gym with one of my friends, and then I'll be joining his practice here when my residency is over.
And so can you tell me what attracted you to chiropractic? Because obviously you're an athlete, you've just given us a rundown on all that kind of stuff. Sound like you're very athletic, you're relatively good at that stuff, but you're very passionate about it, so I'm sure that has something to do with it. But kind of why chiropractic in the traditional sense?
I didn't have a good reason for picking chiropractic specifically going into the program, which I don't think is incredibly uncommon. I was seeing a chiropractor all through high school, and it's just kind of like, yeah, this is just kind of what we do, especially in small town South Dakota, where it's like your nearest doctor of any form is probably a chiropractor. And so, we'd go see him when I got banged up during, football season, basketball season, whatever it was. Sometimes just go because I didn't want to be, I'd want to get lunch with my mom. And so I just, leave school, go to the chiropractor's office because I had a doctor's appointment. And then my mom was across the street, and I was like, hey, Mom, you want to go get lunch? And so we'd go get lunch or whatever, too. Yeah. So pretty cool through there. And it was kind of that PT chiro route. I tore my ACL, actually, my senior year of basketball. It was a really cool way to do it. I went for a dunk and missed. So the missing part, not so cool. But I had gotten one the game before, and so I tore my ACL, kind of went through the PT process. Thought that was pretty cool. And actually in hindsight, I didn't realize in a small town, that same PT, she would work with us high schoolers in the morning, before school, and then she would go work with the nursing home during the day. Well, I didn't know the nursing home part. That might have been a bit more of a detractor if I would have known that at the time. And then again, after school, she's getting the high schoolers that, were still hurt there too. So got through undergrad, and it was like, well, they're kind of the same. And then talking to Dr. Stark, especially too, I think that was kind of where I was a little on the fence. I wasn't sold on chiro necessarily, because I was like, well, you crack backs, right? And then getting into kind of talking to Dr. Stark, and he's, he's done the Olympics, he's done all these different things, and just seeing his thought process. And he also had an exercise science background, so I was like, if this is what I can get to, like, I want to be that guy.
We have a lot of people that listen to this podcast from around the world, but we also have quite a lot of people from New Zealand. And as I explained when we were off air, New Zealand has more of a traditional ideology around chiropractic, especially in the education. We have one school and they teach static listings and old school subluxation model and et cetera, et cetera. So to those people, and also to chiropractic students around the world that may go to a more traditional school, what can chiropractic be? Or what is it to you when you integrate the rehab, when you integrate the exercise science, when you integrate the PT? What can it be, and how does that look for you? Because I'm assuming that's kind of the life you're living at the moment, right? Your day-to-day.
Yeah, absolutely. Musculoskeletal care overall. That doesn't just mean, taking care of the spine, although that is still, we learn the importance of it. And I think that's something that before starting chiro school, I was just like, yeah, the spine's there, like it's fine. But understanding the whole, like, how biomechanics, bottom up, top down, like we can kind of, depending on what the sport is, what what their daily life is, how important the spine can be. But we can be the musculoskeletal care provider across the board, whether it's, we can be on the sidelines, and that might vary state to state or country to country as well too. But I can be, in my current position, I'm on the sidelines frequently, and I'm the only person there. So for high school football, like that's what my last couple of days have been. Friday, I was sidelines for a high school football team that we work with. There, kids get cuts, scrapes. They roll their ankle. I come check them out. If I need to tape them up, I'm like, all right, get back out there. If I'm looking at them like, hey, like this is pretty gnarly, like you got to sit, like you're done, kind of thing. I get to make that call. So that's kind of on the front end, and we can be the back end. We can do rehab. We can do the full gambit. I have plenty of my own private practice patients too, who they come to us when they have a foot problem, a knee problem, an elbow problem, and we're the ones like, all right, like let's get you back doing this. We own a gym, so being able to like let's incorporate. Are you a high school football player? All right, let's get you back out there. You got a game on Friday. Let's start doing some pressing movement because you're going to be just tackling people or whatever it is. So musculoskeletal care on the whole end, and then even for those that aren't sports chiropractors, just being that healthcare advocate of being able to like, hey, you need to consider maybe looking into, these conditions because hypermobility is actually something we're seeing a lot in our student population. And so it's okay, there are considerations for that long term. And that isn't just, yes, maybe you shouldn't get adjusted a ton either. And maybe, you should be lifting weights for the more of a stability component, but also like what's that going to look like when you're 50, 60, 70, and you're not going to lose your hypermobility. Like there may be other things that coexist as you get older too.
So what I'm kind of getting from that is that you almost play this role of a PT, an ATC, a DC, a physio, a trainer, a coach. Like you get to kind of amalgamate those professions into one. You train as a chiro, but then obviously you go on and you do extra education. As far as I'm aware, I think your undergrad was exercise science. Is that correct?
Yep. Undergrad and masters are both exercise science.
Oh, and masters. So is that something you would suggest to somebody who's in chiro school or has just graduated? They got the numbers up, they're seeing patients, they're racking and cracking, they're hitting the flying 7, racking and cracking. They're like, man, is there more to this? I want to do more. They see, I think it's quite popular, the whole rehab thing, especially if you're on social media and you're in our year group. I think it's very natural for people to want to kind of go down that route because they see it a lot. It's around on social media. What kind of advice do you have to those people that just graduating? I mean, when we look at the stats, personal trainers don't last 6 months in the industry. Physiotherapists don't last 5 years in the industry. Me and Luke were just talking about it yesterday. It's a hard industry to be a part of. And so what would you say to that new grad when it comes to, hey, they want to move into the rehab space, but they just don't know how?
Yeah. I think a lot of that comes down to the business stuff that we really don't get the formal education on. And that's, because as much as, I love doing this stuff, if I only saw 3, 4, 5 patients a day, that was what I was dealing with, and I could make ends meet, that's perfectly fine. But I think a lot of it ends up coming down to like the business side of things, which is what gets really tough. I know there's people out there that are, business coaches, stuff like that too. I'm sure they have that nailed down. But if being the like entrepreneurial person, isn't quite someone's thing, trying to find the right environment, and if you're willing to move and to find it, it exists out there. There's a couple of jobs that I was looking at when I wasn't certain if I was going to get the job here in Minnesota, that I was like, well, if this isn't what works out, I want to make sure I reach out to these people. If you're kind of tied down geographically, it's probably going to be a bit more of a challenge, but being able to find ways to emphasize the importance of that for whatever community you're in. And again, maybe it's not making the immediate jump, but like, hey, let's get you moving. Let's, do some McGill Big Three stuff if we want to do that for, just simple rehab if you don't have the space for it. And then maybe eventually, okay, well, you can do this and, kind of getting that gradual implementation versus kind of just going like, hey, what we're going to do is we're going to do like plyos and you're going to do cartwheels and like go full CrossFit on somebody too. You need to make sure that you can kind of find that range and start somewhere and again progress your community or whatever it is.
Yeah, I mean, it reminds me of your story, Luke, if you want to share about how you used to take patients out back and do rehab with them at Cara School.
Yeah, so we had a massive clinic that we were operating out of as interns. It was probably at least, 15 to 20 tables sort of in one mass area. And then surrounding that, you would have these closed off consultation rooms that were only done for the new patients. They would be in there for their first visit just for patient confidentiality. And then following that, you'd take them out onto the floor and just do the whole adjustment thing and 10-minute appointment to get that all signed off. But as I started moving through my years, I was like getting patients coming in with sort of other issues that they were trying to tell me about. And at first I was very closed off. I'm like, oh man, like, I can't really deal with this in this type of setting. And then eventually I remember one patient, he came in with he was a CrossFitter as well, getting some type of impingement at the anterior part of the hip. And so I adjusted him, and then with the last sort of 5 to 10 minutes, I took him out to one of those side rooms and started playing around with a lot of hip range of motion, did a little bit of soft tissue, ran him through a couple of sort of mobility-based exercises, and then he was on his way. But I was treating a very fine line for about a year while I was in college.
The context of that story may not make sense to some people listening. The premise of that story is that you weren't allowed to do anything but adjusting the spine, and usually just the spine too. I mean, on the first day of chiropractic college, the president of the college came in and sat us all down and said, if you do anything but adjust the spine, you're not a chiropractor. So this is what we're working with, and so it's very, for Luke to be doing that was kind of funny.
And if you're not clearing a certain area of the body, whether that's an ankle or the front of the hip, then you're adjusting the wrong segment, and that's not a subluxation, it's a compensation. So that's what you're dealing with as well, right?
Yeah. So you know all about that, I'm sure.
Luke, you probably had patients coming in like Dave Chappelle, like, you got any more of that rehab? What's going on over there?
Yeah, we had a friend that was, we told him about the whole McGill stuff, and he ended up designing some pamphlets that he was handing out.
Yeah.
Did he get in trouble for that?
Yeah, he got in big trouble, man. He was.
Oh my goodness.
Yeah.
Yeah, and then there was also, when we were there, one guy got chewed out for suggesting the McGill Big Three for someone, and they got pulled aside and told very swiftly that you're not a physical therapist, you're a chiropractor. And so, all of this was just the tension, you can imagine. It's the focus was on the spine. And so I suppose that leads me to my next question. How do you integrate every other part of the body into your treatment? As a sports chiropractor is what you call yourself. Is that your title?
Yep.
Yeah. You obviously, for you, that sounds quite foreign to just focus on the spine, right? That must sound quite foreign.
Absolutely.
What's your integration process when it comes to that? I'm sure you must have strong opinions on it.
Yeah. So this will sound a little bit kind of philosophy-based-ish, but I mean, taking it and applying it laterally here. So, I mean, obviously, everything starts from the ground up. So I've had numerous, I mentioned my ACL injury, but I've had 4 knee surgeries. So I've been around the block quite a bit. Everything starts from the ground up, especially when you can't use a limb. All of a sudden you just, the amount of just body that wastes away when you're not able to use a limb. It shows the importance of, making sure that, your feet are still doing their job, and whether it's, statically, dynamically, however that can kind of work through there, working its way up, being able to just take all the compensation, like you said before, it's something that's compensation. Luke, what'd you just say with the?
Oh, subluxation.
Yeah, it's not subluxation, it's compensation. Well, it's there is compensation throughout the body, and that still applies, right? And so as much as, again, if I'm looking at shoulder stuff, I'm going to apply the T-spine. If I'm looking at, I might even look at the lumbar spine still, because I can, for limited one area, I got to be able to piece the things together. But if we're seeing knee stuff, okay, well, let's see how the whole body moves. And then maybe I can look at different spots as I'm going through that. So a lot of the stuff that we're actually incorporating in our on-campus clinics at the school is full body objective assessments. And so whether it's, we can still try to do local stuff. So if we're dealing with a medial epicondylitis or whatever, maybe some of that grip strength. But if we got low back pain, all right, well, let's look like a Sorensen's low back endurance test, but also let's look at a full body weight squat. Or if they're like a CrossFitter and they want to make sure they can do, snatches or cleans or whatever it is too, okay, then let's find a way to do that loaded or unloaded, and apply it laterally, apply the thought process laterally and go from there. So, yeah, just trying to, one, start with your regional and, see if there's anything that's very focal, but don't, take the next limbs into account and seeing what's, what the whole body is kind of working into from a global perspective.
And what does so obviously you mentioned your residency. How long do you have to go with that?
So I actually just got extended for a third year. The residency here at Northwestern is usually 2 years. And for those that are listening, when I say Northwestern, I mean Northwestern Health Sciences University. There's like the big Northwestern in Chicago for the American listeners, if you know where that is. For people local to Minnesota, if anybody does listen to this, there's also a University of Northwestern St. Paul. So I'm going to mean that as the chiropractic school Northwestern. So it's a 2-year deal, and a lot of it is just kind of self-guided stuff. There is kind of some general parameters, but 2 years, and I just got a third year. I'm actually being sponsored by Foot Levelers, which is a custom orthotics company that kind of has its origins founded in the chiropractic profession. So I am a little bit of an aberration getting a third year at the school.
And so what's the plan? I think you mentioned you're going to be working, you've got a bit of a plan after the residency?
Yep. So back in March, with one of my really good friends, we met in college 10 years ago, which is a little bit scary to say out loud, but we met 10 years ago in college, and we were both exercise science majors. I convinced him actually to go to chiropractic school. He was also thinking PT, and I was like, hey, buddy, like, how about we do this together? And long story short, we did. And then when I came back to Minnesota after being back in South Dakota for a year, I was like, hey, do we want to start planning this now? So we actually started planning everything 2 years ago. There's been some bumps in the road for better and for worse, but we eventually have gotten to the point where we bought a gym 6 months ago now, and then I'm joining his clinic.
Nice. So
yeah.
Is the clinic in the gym?
All in the same building, yeah. So we have the ability, that's literally 10 steps down the hall.
That's cool. How large is the gym facility?
I want to say somewhere between 2,000 and 2,200 square feet. So not gigantic, but definitely enough where it's like, we got plenty of machines, we got every body part covered, and then some wiggle room for space as well.
That's cool. Yeah, I like that. It's that integration, like we were talking about before, of kind of all of those models or those methods that really makes the treatment highly effective. And I just find it so easy to kind of get pigeonholed. We often say on this podcast, a friend of the podcast, Andrew Locke, he often says when you graduate to lose your religion, meaning once you graduate, it's stepping away from just that kind of ideology or stepping away from being so connected. And I always like to follow up that statement by saying, well, how do you know someone's a vegan, or how do you know someone's a CrossFitter? It's like, well, they tell you. They tell you. And so it can be a little bit like that, like with the keto or the vegan or the cross, all these kind of communities online and communities throughout the world. But you can get so attached to it. And the same can happen with physios and chiros and athletic trainers and exercise physiologists. Like, people can become so entrenched in the philosophy of what they're doing that it can become almost who they are. And it's so important to step away at that and be like, hey, how can we amalgamate what is evidence-informed or evidence-based treatment so that we're doing a similar thing? And me and Stephen often talk about on this podcast how we can all come from different professions, we can all come from different paths, we'll have different upbringings, slightly different education, but we're going to land somewhat on the same page if we are following proper guidelines. And that is why we have people from all around the world, but we have these really, really interesting, productive conversations where it's always awesome to learn and hear about. Because if we're following those guidelines, and if we're all committed to reading the research, we're all committed to learning, to working with patients, to having that kind of experience, we are going to kind of land somewhere on that page. And when you don't, like, when someone I respect brings up an ideology or treatment or whatever, I think it's wrong, rather than me being like, that person's wrong, I always try to check my own bias and be like, well, how can I think about the application of that, maybe in terms of their clinical judgment, or maybe in terms of the research? How could I go back to the drawing board? How could I rethink it? This happens all the time because I've got so many friends around the world. So, what's your take with social media? Is it a big part of your business? Do you think it needs to be a big part of your business if you're in chiropractic? Do you use it a lot in terms of advertising or putting yourself out there as a chiropractor so people know who you are around the world? It'd be interesting to hear your thoughts on that.
So I think that depends on how you connect to your community. A lot of my schoolmates and classmates, some of them are being a little bit more non-traditional, and not necessarily like doing the brick and mortar, or at least not doing like a giant brick and mortar type practice. A lot of them are doing it kind of online, in which case, obviously, that's where like your social media presence is going to be like your livelihood. Where the town that I'm in, so it's Hastings, Minnesota, is where where our gym and clinic is. So it's a little bit outside of the Twin Cities metro here in Minnesota. So there's still some roots of like farm town type stuff, generally speaking, a little bit older. So that's where like getting a little bit more old school, like literally printing out flyers or handing on business cards is a little bit more of the way to connect.
Yeah.
But it's also that balance of, and I'll speak a little bit more to the gym. That's where we put more of our marketing kind of this summer, is like Facebook, just literally word of mouth through Facebook. I kind of the one a little bit more responsible for our social media stuff. And I'm not making anything like world beating. It's nothing where like, if you guys were to look at it, you just be like, yep, like very familiar kind of thing. But getting it out there to the moms or the grandmas, between the ages of 40 and 70, and they're like, oh, did you see what's on Facebook? And I'm like, I mean, hey, it's got to go somewhere. So just getting the word out there. For me personally, I like to use it a lot to stay connected to. I mean, Steven and I have had conversations as well on Instagram, whether he shares the stupid dad jokes that I love to laugh at. Thank you, Steven, for those. Actually, I had an intern this summer. She loves dad jokes, and she started reading a couple off, and you had shared them like days before, and so I knew the jokes because you had shared them on Facebook. So big shout out to you for that one. But yeah, just being able to stay connected. No, those are absolutely gold. She ended up coming in with like imagine Cards Against Humanity size like box. Like she had dad jokes, like that many of them, and I was like, all right, you win, like it's over. But nonetheless, just being able to stay connected to, and I know during my years as a student, again, staying connected or finding the different schoolmates, especially like we mentioned off air, the pandemic was good for reaching out and connecting to other people. But for me, just like drawing from people with more experience. One of my master's program teachers, he's also a Chiro and PhD, and he's got every letter behind his name twice, but he's in Chicago. His name is Brian Serrano, and he's constantly posting research, and he's that man. I don't know if he sleeps. I don't know him super well personally, although he gave me a really good reference once upon a time. But that man is just constantly doing stuff, and so pulling from him, not taking everything, as gold, but being able to take it, process it myself, and what's being out there that my students at the Northwestern might also be seeing. And then, if they're like, oh, hey, what do you think about shockwave for neuropathy? And I'm like, well, like, I don't know. At this point, it's like, all right, I've seen things work. I've seen things not work. I know the mechanisms, and like, this is how things can go. And then also playing into clinician experience.
I know last night we were talking a little bit about knee rehab. Do you want to give us kind of your insight on the nuances of that?
Yeah. So I'll go through not short list of my knee surgeries. So tore my left ACL in high school in basketball, like I mentioned, tore my right ACL during chiro school. And then while I was recovering from that one, I developed some pain and discomfort in the left knee, found out I had a 1.7 centimeter medial femoral condyle lesion that needed to be fixed. And so I had the original scope for that, where they went and obviously just cleaned it up. And then they took some chondral cells and grew those in a lab, and then they went in 2 or 3 months later, and then essentially just kind of like plug the lesion. And they also did a high tibial osteotomy. So they broke my femur, broke my tibia like 3 or 4 inches, somewhere on the shaft, on the upper end of the shaft. And then they put the plate on there. There's a certain degree. I still know my surgeon. I talked to him. At the time I didn't know enough to ask like really high level questions, but I was questioning. But they broke my tibia, put this plate on there, and then it re-ossified. So my left tibia is straighter, which probably means I also have a longer left anatomical leg than my right. So I was very curious. I did want to see. We had an old activator doc on campus that I was like, I kind of want to go see him just to see and like not tell him, just to see. But that's neither here nor there. But the ACLs, those were pretty straightforward. I was super lucky with the rehab on that. But one thing that's kind of taught me is really making sure that you have the criteria for like stage advancement. As if it's been caught on camera here a couple times, I do have an affinity for sugar, which means that there is some local inflammation that tends to not leave my joints. I'm very well aware of that. And I was icing like a madman. I'd still wear my compression sleeve, but being able to have that criteria to go from, step 1 or phase 1 to 2 to 3. And it's really important to kind of have those goals. And I mean, because if we have that knee effusion, we're going to see some of that quad activation, it's just going to be lagging because of the inhibition of the muscles there too. So that's a really big component. Being able to get to the point where, okay, yes, we have our strength and having a background in strength too. My baseline was higher than your average patients, I'll say. I mean, maybe your average athlete, I'm probably smack dab there in the middle. But by the time I got moving, I was like, all right, well, now I can advance faster. So being able to, articulate with the patient, whether it's patient facing or for me talking to students, and Stephen, you probably do this with students as well too, but being able to communicate with them of like, when you're working with patients, let them know the expected timeline, but also know that for that individual patient, it can vary. And so then when we get into like the more advanced rehab, it's all right, what are we focusing on? Because we have a million different things. Do we need to hyper focus on the intrinsic muscles of the foot? Not necessarily, because maybe we can get two birds with one stone if we're doing like step downs and some kind of decel stuff. We're working on, other parts of the limb without, hyper focusing on, it's got to be the knee. It's got to be the knee. Yes, the quads are a huge factor in knee rehab, but we need to make sure that we're setting up all the stones around it too. So we're not banking on the knee, because if we just get the knee stronger, but the foot's still crap, or, the glutes are just awful, like we're going to be seeing knee valgus later on. It's like, well, why am I still seeing knee valgus? Well, it's because you don't have the supplemental strength either above or below or something of that sort too. And then challenging kind of the extra criteria too. So if someone's trying to, like myself, still a huge recreational basketball player, I try to, unfortunately, the last 9 months I haven't been able to play a whole lot. But I mean, even post that last knee surgery where, I was non-weight bearing for 8 weeks, I've played in 4 or 5 different basketball leagues in the last couple of years because I'm still trying to play. And so we have the 3-hop test. That's kind of the current gold standard, right, for being able to return to play, return to sport kind of thing. But being able to challenge your athletes on, how can we get as close to the sport as possible? How can we get some of those, those demands that maybe we can't anticipate? How can we get those to apply to rehab and be able to prepare for sport? And then obviously going from the kind of the spectrum of rehab to performance and blending that towards the end of rehab.
That's good. I like that. We talked about this when we had exercise physiologist Alan English on. We really kind of zoned in on that missing gap between rehab and back to play or back to sport, back to performance. But then also that gap between initial acute care with your practitioner or your clinician and rehab. We do certain things quite well, but then the transition between that and the next, I suppose for you bridge that first transition because you do both. But you can imagine going to see a chiro who will do the chiro thing that doesn't have much. They understand, they can adjust, they know a little bit of rehab, but they're not well versed in the rehab. There's then this kind of disconnect, and then you may, for example, I'm not sure what it's like. Well, I do know what it's like in America. Exercise physiologists in America are kind of like trainers, right? Advanced trainers. But in New Zealand and Australia, they're allied healthcare professionals. So over here, we pick up a lot of that rehab, where a lot of chiros and physios will do the acute, and then it gets kind of referred on to an EP for that. But what we often notice is there's just balls being dropped between the transitions between acute and then chronic issues, but then also acute and chronic care. So it's interesting that you said that. I do have a couple of questions here as you're talking. First things first, do you think knee valgus is predictive of injury?
Depends on when are we seeing the knee valgus? So is it more like a jumping mechanism or landing mechanism? With the landing mechanism, again, case by case. I mean, that's the classic "it depends" answer, right? Everything always depends.
Yeah.
But if we're getting it like on a jumping mechanism, it's probably less of an issue. If it's an uncontrolled mechanism when we're landing, that's where I'd consider it more problematic. Just because, I mean, simple biomechanics, like that is a force that can easily be overloaded. We're stressing, the ACL pretty intensely. Now, again, if it's controlled, then maybe it's a normal for that person. Definitely gonna be that gray zone of like, how far is too far? I can't give you like a oops, sorry, buddy. Petting my dog here, and he's very intently listening to me. But yeah, being able to say how far is too far is I mean, I don't know if there'll ever be a concrete answer on that one.
Yeah, it's interesting because you've obviously got a lot of people that are big into biomechanics, and they will talk about the application of force being migrated onto tissues that may not be able to handle it and overloading, etc. And it also seems quite intuitive if you're an athlete yourself that would be an issue. Jumping or landing or in anything like that, planting, twisting, moving, anything where there's going to be that kind of force mechanism moving through those tissues. It's very intuitive for us to be like, as athletes, for us to be like, I don't know if I can call myself an athlete. I'm a powerlifter, but
different strokes for different folks.
Yeah. But like as a lifter, I will say it's very intuitive for me to say. I obviously have an opinion. I've written a paper on it that's currently being peer reviewed. But outside of my opinion on the research, intuitively, it feels like it's a yes, like it matters, right? But then you've got clinicians and physios and people online that now are moving towards this movement optimism streak where they'll be like, it doesn't matter as much. And there's certainly times where that's a very valid philosophy or ideology to have. But I find like at times it can also be quite misleading to be telling new grads knee valgus doesn't matter, or it's not a consideration that you should have. And so that's why I asked that question, a bit of background.
And that's something that I'm seeing a lot in students now. That's kind of the fun part about being back at my alma mater is some students just like, oh, it doesn't matter. And I'm like, yeah, see, I was there. I know exactly where you're at as a student. I was like, because I was there. Like, diagnosis doesn't matter. It's just shoulder pain, shoulder pain. Well, it's like, nah, like, is it more like nerve entrapment? Are we looking at like, do we need to like, kind of like offload things? Is it a tendinopathy? Like, we need to be specific in some context too. And getting like into like Oli lifting too, where it's like, okay, well, at the bottom of like a squat, like, do we see like some adductors like kicking in? Is that actually providing more knee stability, more strength? Like probably, because when you have 600 pounds or 700 pounds in your back, like, yeah, you probably need to get it from wherever you can get it, kind of thing. Now, again, whether it's pathological, like who knows? And I think another thing that gets missed in, especially this is where like, do you guys pay attention to like American football much?
No.
Okay, so like, okay, so Tua Tagovailoa for the Miami Dolphins was that Thursday? He got hit in the head.
Thursday.
Yep. Okay, it was Thursday. Thank you. He got hit in the head again, and interestingly enough, by Damar Hamlin, who was the man that died on the field a year and a half ago, whatever that was. But interesting parallel there. Nonetheless, I'm kind of ranting here. But Tua got hit in the head for the third time in 2 years, and he had second impact syndrome last year. And so it's the context of like, is this like a nasty hit or is this an illegal hit? No. But the context of like when it's being applied, and that can change athlete to athlete, that can change day to day for the same athlete. Kevin Durant, like I mentioned, huge diehard basketball fan. Kevin Durant's 7 foot tall. Like he's got some knee valgus when he shoots his jump shot. The prettiest jump shot of like Hall of Fame jump shot kind of thing. But is it a problem? Most of the time, no. But maybe there's a point in his game or in his life or whatever where, oh yeah, like he's going to go for a jump shot or something's going to happen. It's like, well, that day, because, God knows, maybe he didn't sleep well, if he has a kid, it's like, well, now you're getting 3 hours of sleep. Okay, well, now all of these extra factors are playing a factor. And it's like, well, now you're victimizing the knee valgus. No, there's more to the story.
Yeah, it's not a problem until it's a problem.
Exactly. Yep.
And then you obviously have to look at the whole picture. But I think with those guys, especially those top level athletes, it definitely comes down to recovery across the board. There's just so many. It's highly multifactorial, and I know it's almost like people are taking a shift to the point where it's so complicated, and they're okay to say it's complicated in a biopsychosocial sense or a psycho sense, but then with the bio, it's so complicated that we're now reverted to this whole non-specific thing. Non-specific back pain is quite consistent in the literature. I actually think it's so specific that we've called it non-specific. That's my opinion. We've actually kind of gotten to the point now, and you being a knee guy, you might know this, but now we're starting to say that about the shoulder and the knee. I'm starting to hear people say it's non-specific knee pain, non-specific shoulder pain. I know enough good practitioners that if you've got a sore shoulder and you come and see them, they can tell you what it is. And if it's not something biomechanical, okay, potentially there's some psychological stuff happening too. And I've co-managed and referred to psychologists before, with lower back issues, so I'm not saying it's not a thing. But I also work with practitioners that are so good that they can just zone in on it. And then you've got people in the industry saying, well, that's not possible, everything's non-specific. So for the new grad who just has no idea what's going on, what do you say to them? Where do you learn those hands-on skills that you can become that weapon that someone walks in and you can zone in, man, you can get those results? What would you say to the new grads that are feeling confused? Because they are. We get feedback all the time.
Well, if they've got good insurance, I'll tell them to get the injury themselves and go through it a couple times. Once you have 3 or 4 knee surgeries yourself, you get pretty good on figuring what's going on. But if they don't have good insurance, honestly, understanding conditions so well. That's one thing that we've done actually this weekend, this morning. We were teaching a class and we kind of revamped one of our whole courses. So we're trying to make it more applicable and understanding like patterns. So kind of like getting your principles down and like, all right, like what can we do here? All right, this is, we're looking for this mechanism and understanding, all right, with ligamentous stuff, we're looking for like the integrity and we're going through that. All right, well, if that's not it, okay, maybe there's a population issue where there's, they're fitting this demographic, and is there any like anatomical pathology available? Okay, no. If we're kind of wiping away the the textbook definitions, then find like a functional audit you don't necessarily need like a classical diagnosis in the traditional sense. Obviously, it's like, okay, there probably is some kind of like anatomical, especially in knees, like hinge joints tend to be a bit more simple. But like there may be something wrong with that, and give me a functional diagnosis. And a lot of our students are involved like the rehab to performance world, so they're really familiar with terms like tissue tolerance, mobility, stability, and motor control. Okay, well if it's not an ACL tear, which I mean there again, maybe there's an ACL sprain or something involved with that too. But is there, is it just they don't have the tissue tolerance to withstand a churning load, or and that can apply to your average patient too. That doesn't need to be someone who's, playing basketball or volleyball where they're jumping 100 times in a day. That can be, Nancy, who's an accountant who likes to go for walks at the end of at the end of the day. If she all of a sudden is cranking out 10 miles, but she only used to walk 2 miles after work, it's still going to be a tissue tolerance issue.
Yeah.
Now, maybe there's underlying pathology too, but being able to kind of summarize here, find your principles, and then be able to, if there is something that varies, cool, kind of shift from there. And if it's not a traditional diagnosis, then finding something more functional to go with it.
Obviously, there's a lot you can do with putting your hands on and doing a clinical assessment, but the history, it's being able to identify what is happening in their lifestyle that may be overloading certain tissues. Why is that happening?
Yep.
And looking at that. I had a patient that had a knee issue. He can't train, he can't squat, he can't do anything. He's in agony. He couldn't even play with his kid because of his knees. I was seeing him over Zoom, and I brought Luke in on a session just to help out. And in that first session, Luke, I don't know if you remember, but like we just went through some strategies of how to get out of the chair because he couldn't get out of the chair without pain. When we just load the hips, drive the knees out, establish some foot to floor stability, knee to foot stability, hip to knee stability, neutral spine, and just clean up the biomechanics. And people are like, yeah, but he's not lifting weights. It doesn't matter. It's fine. No, he's got a pathology. Force has been migrated into this knee tissue and it's painful. Just by moving some of that force and migrating it into the hips, we were able to get him up and down with no pain. That's just one example because his case was a lot more complicated than that, but just being able to locate those things that may be producing pain and then wind them back, it's a huge thing. Last week I sent Luke a video of this dude. He was deadlifting 200 kg. He's squatting 160 kgs. He's back training hard, doing what he loved. He never thought that was possible because he went to so many practitioners that would they pigeonholed themselves. They couldn't provide him the care he required. He obviously had to end up reaching out to somebody over Zoom, nonetheless, like I didn't even put my hands on the guy, but it's not to say like, oh, I'm amazing. It's just to be like, I see this happening again and again and again and again. And Luke was on that call with me. For us to be able to go through these certain things, we always bring it back to how can we educate those listening, because we find that people want answers. And we had a seminar here in Auckland a few months ago. It was brilliant, but the reoccurring theme, Luke was with us, Luke, but the reoccurring theme was people want answers. It's almost like everyone that knows how to do things, it's like the Wizard of Oz, they're kind of keeping it behind the curtain. And I love to kind of just give as many answers as I can on these podcasts. Every time we have a guest, I like to just zone in. Okay, what is it that you're doing that makes you so good? And so that's the question that I really want to land on. Okay, you're obviously good at what you do. You don't have to be humble here.
I will say imposter syndrome is still real. I think Stephen and I graduated roughly the same time, and 3 years into practice, and I have two mentors at work, one with he's my dad's age, so he's got 30 I'm gonna say 35 years of experience, and I'm like, wow, he's literally 10 times the experience I have, and I'm convinced it's exponential. And then Dr. McDonald, I think she's 10 years out, give or take. And I'm like, even that's 3 times the experience I have. And I mean, I learn things from them every day. If you don't mind me throwing in a real quick story, similar to like your kind of new dad, that reminds me a lot of my dad. So my dad's a classic Midwestern American farmer. He's been beating himself up since he was 12. He's been driving tractors since he was 8 kind of thing. And I mean, I remember him trying to teach me to drive a tractor when I was 10, and I was like, there are so many levers, Dad. And he's like, I was doing this at 6. And I'm like, well, Dad, there was like three levers when you did it back in the 60s. So different story. But he got both of his knees replaced 3-4 years ago. And I remember teaching him to sit down again. It wasn't even the up, it was the down, because he would just plop. And I'm like, Dad, like sit down, make it an active sit. Don't just like get halfway there and fall. And so it was pretty interesting just to, like, okay, cool. Like, Dad, I'm finally to the point where I know some stuff, and you're I mean, he's not going to hurt himself doing that. It's you sitting on the couch kind of thing. But I'm just like, oh, Dad, like if you want to make life a little easier, just be intentional about how you sit down. And he was just like, oh, yeah, I never noticed that. And then real quick side tangent, I'm not going to go too far on it too. But one thing that they don't prep you for as a healthcare provider is how much your family is going to ask you questions and then not listen to the answers to.
We talk about this all the time.
Yeah, bro. I just tell my partner to take Panadol now. They don't listen, man.
Yeah, it's funny that because I did my PhD under a neurosurgeon in Brisbane, and one of the big things we looked at, he has a program called NeuroHab, and I won't go too deep into it. I'll give you a quick rundown. But this guy is a neurosurgeon, brain and neurosurgeon, but he focuses on lower back pain, and he has people come to him who are tertiarily referred, so they're at the end of their rope, right? Tertiary referral. It's like their first go around. They have to go through so many visits by this person, this physio, this. They come to him and they are broken, and they want to go under the knife. He looks at the x-rays, he does a full assessment, and he says, like, we're going to put you into NeuroHab. And they go, what's NeuroHab? It's 8 weeks of rehab, appropriate motor patterns, restructuring how you move, basic biomechanics. We did a study where we looked at 290 patients that went through there over 5 years, and we found that there was, roughly a decrease of 50% in the ODI, right? It's incredible. He's got a very unique, he's got 6 points of performance, and he's got a very specific way of teaching it. And he takes people from at the end of their rope all the way through to being able to squat and hip hinge and live their life. And that is incredible. That is cool to see, and being able to incorporate that myself. But what I'm getting at is our friends and our family, they ask you about their shoulder, their back, their knee. You give them your opinion or you give them rehab and they don't do it. They are 100% sold out for surgery. They're 100% sold out for taking a prescription. And they think rehab is silly. They'll even do manual therapy before rehab. They'll even get a rub down before rehab. They'll get an adjustment before rehab. They'll get dry needling before rehab. And it's a real issue, man. It's a real problem that I've found. So how do you navigate that? And I think you mentioned this on that other podcast I listened to, but talking about compliance on rehab, and I think you said like you've never finished a rehab program yourself, right?
I forgot that was in there. Yeah. Yep.
Fair enough, man. Like I love that you said that, and I'm keen to hear what your thoughts are on that and how you find your patients and how much compliance you have when someone comes in, they want you just to crack them, and you're like, cool, we can do manual therapy, but this is like, you communicate, this is where we want to take you with the rehab, and maybe they're not so keen to follow.
Yeah. So just to clarify, so the all of my rehab, yeah. So I have the knees I mentioned, and then also I tore my labrum in my shoulder in college, and the knee looking like my first knee in high school, it was because I went off to college, and so that was 6 or 7 months post-op, and my mom was just like, I don't know, are you good? And I'm 18. I'm like, I don't know, sure, I feel good. And I was playing pickup basketball like day one of being back on campus, and I was not holding back kind of thing. So I think the fact that I didn't re-tear it is just pure luck on that end there. So somebody, whatever deity that you pray to, it was watching out for me.
Whatever DD Palmer.
Yeah, there we go. Full circle back to Cairo stuff. Yeah, praise Didi on that one. So I got lucky for that one. The shoulder, I'm technically part of like the follow-up portion of the study too, but I was working with a PT or an OT for the rehab for that, and I met their markers. It was just like, hey, you have full range of motion and like you have no limitations, but there was no like, and I wasn't specifically returning to, right? I wasn't going back to play college football. I wasn't trying to do anything. So it was just like, you're good. And by happenstance, I, have fallen in love with exercise myself. So essentially just rehab myself over time. I would have finished the second ACL rehab if I didn't have the additional injury. So there would have been one I would have completed, and then ended up moving for the last one. So I didn't have a physical therapist, although I would say I was doing a fairly good job myself at rehabbing, but kind of circling back to patients. So just laying it out for them, like, hey, these are kind of your options, and not to the point of like scaring them, but it's like, here's the deal. Like, if you've been dealing with this for 3 years, 10 years, 6 months, 3 months, whatever it is, like, it might take the equal amount of time going forward just for you to feel like at your baseline, and then making sure that they understand for coming in semi-regularly. So we try not to oversee our patients. So it's not like, I'm not coming in for 3 weeks or 3 times a week for even a full month. It's usually that like, all right, let's see, 2 times a week for the first week. And then how does it go from there? Do they want to come in 2 more times the next week and then start spacing it out? Or are they able to space it out? Kind of depends on finances too. But, all right, cool. Like what's our win for the week? Have you been able to, at work, did you get your sit stand desk and now you're able to kind of move through there? All right, cool. Had a patient that was able to like walk around it for a concert all of last weekend. And she's like, I wore the right shoes. I was able to walk around. It didn't really catch up to me till Monday. and she was originally having really bad pain on that Wednesday, the Wednesday before. So just being able to reflect on like, this is where you want to be, and this is still how far you've come to, and kind of reiterating that message every single time. And then also challenging too, like if they come in, oh, I didn't do my exercises as much as I should have. It's like, well, did you do them at all? Like yeah, and it felt better when I did them. Okay, cool. Let's stick with that. Like you're doing a good job. We're still seeing progress, and it's going to be up to you to, how fast and how far we progress going forward. And if you get to the point where it's like that's easy now, like remember how hard that was your first visit. Well, now we're going to step it up to this, or like this is what we might do here in the near future. So being able to appropriately reflect on what their past looks like, whether it's success in doing the rehab or the pain that they've experienced before, and then looking forward to like, all right, this is what we're going to do next. This is what the plan is. This is how far you've come, kind of thing.
Yeah, I think as manual therapists or clinicians or rehab specialists or whatever, it's real common to go on this kind of loop of you kind of think that everything you do with your hands is going to change the world, and then you kind of get into this place where you're like, manual therapy is nothing. It's all about patient education. You kind of like go around on these loops, and in reality, it all matters. But to touch on patient education and communication, these two things I want to touch on because you just touched on it. What you said then was brilliant, and I want to highlight that for people listening. It's extremely important that you have to meet your patient where they're at. When it comes to the skill of communicating, could you shed a little more light on how you change your communication style based on the person in front of you? The example you were saying then, you're like, okay, one person comes in, they said they did some. Okay, you did some. Or the next patient comes in, they did too much. Or one person comes in, they did none, and they just want you to crack them again. Also, how important is it to educate the patient? You may have a patient that comes in and maybe you haven't explained the adjustment to them, and then they come back in the next time, oh, my back's really sore after you slam me with that side posture. And it's like, okay, well, was the chiropractor too rough, or did the chiropractor fail to educate them and say, hey, you may have some soreness because this is a really tender issue or whatever. So how important is that education piece, and how do you switch up your communication based on the person that's in front of you?
Yeah. So if you guys haven't noticed by now, and this is the perfect thing for being a podcast guest, is I love to talk. And so sometimes I get in my own way there. And actually, I immediately thought of an example about 3 months ago where I didn't communicate well enough. Had an older gentleman that came in with some low back pain. And in the States here, we're a little bit restricted as a non-insurance based clinic. Like, with Medicare age patients, we cannot adjust the spine. And there's a whole many like details to work around that, coming with low back pain. And I was like, all right, like I can evaluate him across the board just like I normally would, but with treatment I have to make sure that I'm getting the appropriate things in there. And he's I think in his 80s. His daughter, who's I think in her 50s, is one of our patients too. And so she's been seeing us. She highly referred, and not used to seeing the Medicare age patient. Like I've seen a couple here and there. Maybe they just turned 65, and I've been seeing them for a year or so. But comes in, I'm like, oh man, I got to get creative. And so for him, it was all right. Well, like, what are our big things? If I can't adjust, right? Not everything's a nail. I'm not a hammer. So I was like, oh, manual therapy and exercise. And so went through and explained it to him, and I did a really good job of explaining the exercises. I didn't do a really good job of explaining the possible outcomes for the manual therapy. And so I was like, yep, exercises are gonna be good. Like, this is what we want to work on, getting some strengthening here, kind of help you with stability there, et cetera, et cetera. And then I was like, all right, let's do some manual therapy. And so I just, kind of worked the guy's glutes. Again, older gentleman, so not like super muscular bound, and came in for his appointment the next week. And I was like, how'd things go? And he's like, yeah, it went really good, but my wife told me that I had big bruises on my ass. And I was like, oh man, I forgot to tell him, like, yeah, like, some hands-on stuff, like you might have some, some temporary bruising. And he's like, I was super sore for a couple of days. Again, older gentleman, not used to it. So I communicated well on half of it, not so well on half of it, but small victory. He was like, I have no pain today. And I was like, cool, let's do maybe a little bit less than what we did last time, review the exercises, maybe give you one more to step up, and then just come to us as needed, kind of thing. So for him, he was very inquisitive, but then we get the farmer type who, they just want to get whacked and cracked, kind of thing. Funny enough, we have someone we exchange services with, and that's kind of all he wants. And again, it's how much of the battle is worth it. If they're still coming in, they're getting treatment, and so I'm not going to turn them away, kind of thing. And I might, especially I've got to know this patient specifically pretty well, so I'll kind of like throw some jabs at him, or kind of give him a little wink, wink, nudge, nudge at some things every once in a while. But knowing that he's going to come in when he needs to come in. Like, I gotta, again, just meet him in the middle, and maybe it breaks through one day when it's like, oh yeah, like we did this and like it helped a lot. But that's part of the burnout where you know what battles to fight, know which ones not to, because ultimately for seeing patients, that can still be a win, whether or not they're doing everything we want them to or we think is the best treatment for them. Since we're on a podcast, like Joe Rogan, I love Joe Rogan Experience. I was listening to that, and that's probably not its earliest renditions, but definitely one of the earlier times, like 2015, 2016. One of my roommates kind of got me onto it, and I was like, oh, I'm here for it.
Yeah.
And he had a guest on there that I want to say she's got like a social media handle. It's like the Science Babe or something, and
Yeah, I've
she's
seen it. Yeah.
a dietitian. Yeah, that was the first time I heard. She was bashing Cairo, and
Oh
I
yeah,
was like, first of all,
Cyber.
this seems, yes, there we go, yes. And it seems out of pocket. And then some of the shit she was saying where so many percent of people eat healthy. And Joe was just like, you think most Americans, or I don't know if it's Americans or who it was, but like, you think 80% of Americans eat right? And she's like, yeah. And I'm like, first of all, you're pulling that out of your ass. I would love if Joe Rogan was a fan of Cairo because, I mean, some people listen to him in the first place. And it seems like that's up his alley. It's just the one specific thing that he had a bad experience with that,
Yeah.
again, saw it one time and was like, nope, that's it.
Yeah, he had a herniated disc, a cervical herniated disc, and the chiropractor did a compression test, and it was asymptomatic, or it was a negative. And so he told him that you don't have a herniated disc. And obviously, Joe is he was a purple belt at the time. He's black belt now, but in BJJ, so people are cranking on his neck, and he couldn't do what he loved. So there's a lot of emotion involved, and he eventually went to a doctor, had an MRI, and he had a herniated disc. Again, what that really means, whether or not that was even symptomatic and accurate with what we know with imaging. But
Yep.
unfortunately, yeah, he's dogged chiropractic, and I've really wanted some really good chiros to go on that, but it's just never happened. It's only been people that have kind of sticking up for chiro occasionally. A few people have stuck up for chiros, but that side babe, unfortunately, a lot of people would have kind of heard what she was saying. The thing that's most frustrating is that a lot of what she was saying was correct. It was just out of context, and they didn't say any of the good stuff. Now, you can't explain chiropractic based on 140 years ago and not say any of the new stuff. It's just like
Yep.
you could
Yep.
do allopathic medicine. You could talk about this crazy stuff, man, like mercury and the humors.
They used to bleach like the what was it in the Civil War? They would bleach like the walls because they're like, oh, it's like no, you need to disinfect the area. Like it's not the air. It's like you need to be
Yeah.
sterile.
Yeah, and when they figured out you have to wash your hands before you do surgery, little deaths went down dramatically. Freaking drill into people's heads for mental problems. Like, the history of medicine is much darker than a magnetic healer that decided to adjust the janitor 140 years ago. So I thought that was a bit disappointing. But on the topic of imaging, because obviously we understand, not that it's unreliable, because it's not, but obviously when it comes to assigning pathology or symptoms to a certain finding that's on an imaging, whether it's MRI, CT, or X-ray, that's very interesting. But hey, you seem to be very into knees, and that is one interesting thing about knees, isn't it? That you can most certainly have some discrepancies between what you would see on a on an image versus kind of what someone is in terms of their symptoms, and how those two things kind of line up versus some of the research on the placebo effect. What are your thoughts on that? Because that's an interesting conversation, isn't it?
The imaging, the one thing that just blows my mind is like when you get into arthritis, and I mean, everybody and their dog is going to have arthritis in their hip or their knee or something at ankle at some point. If you live long enough, like it's going to happen, right? They call it an age-related change now. It's not wear and tear. Also, if you decide to again go into the knife a few times, like it might come a little bit earlier. If I have arthritis in my left knee at 40, like I'm not going to be surprised, but it's not going to stop me from doing what I want to. So,
Yeah.
but yeah, just getting into like the necessity for imaging, that's a big thing that we've been trying to teach at Northwestern here, and just preaching like what is your criteria? Is it helpful, like being able to explain for is this arthritis, what kind of condition is it? Are we looking at like psoriatic arthritis or rheumatoid where we have maybe more factors? Is that playing a big enough factor in the treatment, or are we looking at more of the daily habits? Because if it's a condition they've had, well, okay, that's always been there. Just like maybe a herniation. Well, like has that herniation always been there? I don't know, but look at your daily habits. All right, well, have you changed anything? All right, well, we have some positive finding on the imaging. All right, cool. But is that going to make or break our decision making? Not necessarily, because it's more so, it's just, again, another tool to examine. Now, if you're looking at like a completely, MCL, the unhappy triad for the knee, MCL, ACL, and medial or lateral meniscus, like, okay, yeah, there's a lot going on there. What do you want to get back to? Like, they should probably go in there and clean some of that stuff up anyway, because it's going to be paired with functional deficits. But if you're going in there and it's like, oh, we have like, medial osteoarthritis of the knee, it's like, okay, cool. Like it's probably because you're, 40, 45, 50, 55, 60, whatever. Like that's just going to be there. Personally, like before they straightened the one tibia, I was incredibly bow-legged on both sides. That's going to cause more compression on that medial side. Like it adds up. So again, important factor, but knowing when to pair imaging up with like functional outcomes is going to be the biggest thing that we're kind of like making sure our students are more aware of. So it's not just like the frustrations of, and actually this is something we ran into recently. One of our patients at my clinic down in Hastings, our note, like we did a great, like I didn't see the patient specifically, but my buddy did, shoulder exam. Like it was the whole like full blown history, doing every cluster you can think of, for slap bicep tendon or slap lesions and bicep tendons, and going through for apprehension and like impingement, the whole workup. And then, all right, cool. Like we think you should go see an ortho. Get the note from the ortho like a week later. It was like crank, uh, Hawkins Kennedy, order MRI. It's like, okay, cool. We did those two already. Like we knew that. And then they get the MRI, and the MRI was like, oh yeah, like partial thickness tear of the right supraspinatus or whatever, like, a millimeter of depth or whatever. And it's like, okay, cool. So like, just because we don't have access to it, we have to do our due diligence in our exam. Again, find our functional deficits, and it's like, well, we can do our manual therapies to kind of alleviate some of that pain, and then let's start the rehab.
Yeah, one of the things that we were educating on at the seminar we had recently was the functional diagnosis. I find a lot of new grads or people that get caught in the weeds when it comes to like having a clinical diagnosis, because when you go to kind of chiro school or physio school, whatever, I know chiro school's big on this. They kind of push the doctor thing on you. They're like you kind of almost get a Dr. House complex where you're kind of like, oh man, like I'm a primary healthcare practitioner and I got to catch this. And then you've got people that are like, if you're not catching 2 strokes per year, you're missing them. And it's just all this, all these things. And it's kind of just a bit of a fear mongering, because I say to people, look, yes, you got to know your red flags, but it's okay to kind of have a functional diagnosis and to kind of cling on to that in terms of your confidence. Like, yes, okay, maybe you're not confident in certain things, and we can talk about that as another conversation, but focusing on being able to be really good with your assessment to the point where you can find functional deficits and then work on those, I find that empowers people, especially when it comes to the imaging, because if you're assigning pathology or pain to an image, you better have done a pretty bloody good job with your functional testing or your hands-on assessment or your assessment full stop and your history. I do a lot of lower back. You can walk down to a mall and ask 10 people to get MRI, line them up on the wall, and 9 of them will have, changes, and they'll be asymptomatic. So it's very, very difficult. So many times I've had patients where the doctors assigned their issue to what's showing up on the imaging, and they come to me and I'm like, I'm not actually sure it's that. I think it's actually this level. We also know that there are functional deficits, but also dynamic changes that you can't even pick up in an MRI, especially when it comes to an intervertebral disc, which is highly, highly complex. Again, I'm not a knee guy. I'm more of a back guy, so I know more about that.
Meniscus is the same way, right? You have different layers of fibers, different red zones, white zones, and then in between the whole thing.
Exactly, and people want to look at it and they want to extrapolate out information from ligaments or tendons that they function in a line of pull that is very unidirectional. And then we're talking about intervertebral disc, where you've got these oblique fibers at a 30-degree angle layered on top of each other, and anytime you've got any rotational or lateral flexion or extension or any motion through that, you've got tension and compression and all different types of stresses happening through that one thing. So it's very, very complicated. It sounds similar with obviously with knee stuff, and you get to a point where it's like I was saying before, things almost get so complicated that they're so specific that they become non-specific. So it's like, I don't know, I just find myself like, oh. But I wanted to just touch on that, the functional diagnosis. That's something that's come through a few times in what you've been saying, and I really do agree on that. I think that's an awesome thing to talk about, and if people want to get better, that's one of the first things I say to them is like, hey, just really nail down your assessment, nail down your history, use your clinical findings to kind of support and compare those back up with your history to the point where you're starting to build an idea or a functional diagnosis. Don't get so bogged down with feeling like you have to be right with everything clinically. And like I've had pushback with friends that are like, we are doctors, we have to be at that level, but you're not an MD. So there's levels to this game, man. I know Steven's a weapon when it comes to picking up on stuff, so I'll send him shit if I want his opinion. Like you can reach out, you can ask for help if you're not sure. Everyone's got their strengths and weaknesses as well.
And one thing that I see a lot with our students too, in terms of like finding a functional deficit. We have our on-campus R2P club is very has a pretty strong pull with our students, and R2P has like the MoPal, TPI, SFMA, so it has a lot of those things on there, which I think is good for our students to at least have exposure to that. Some of them maybe diving too far where it's like that's the only thing they do, and it's like that's good, that's a good system to have, but just like anything too, right, have your system and then be able to play off of that. But so many times it's, oh well, I want to do a vertical jump or something that's maybe a bit more athletic. Well, it's like, well, I'm not going to do a vertical jump with my 76-year-old, grandma she's crushing her deadlifts, but like for her, maybe she's coming with knee pain. And I'm like, as I listen to her story, I can find a functional deficit that applies. And so she's like, yeah, having a hard time going up and down stairs. But bam, like there you go. Like you mentioned before, patient history is so important.
Mm.
Sometimes your patients will give you the answer, and you just need to be, have not enough of an ego where you hear it and you go, okay, cool, like that's what we're going to do.
Okay, so I'm going to finish up with a bit of fun. So what I've done here, I've actually pulled up the one and only legit and bullshit that I used for Stephen when we did Stephen. So there are some interesting things in here. Because I don't know you personally, I couldn't tailor any to you personally. So I try to tailor them as well as I can if I know the person. So I think if it was good enough for Stephen, hopefully it's good enough for you. All I want is a legit or bullshit. I don't want anything else. You can now say pass and we'll move on.
Okay.
And then if you do want to explain your position, you can always jump back at the end of the segment, explain it as much as you like.
Perfect. I'm putting my feet on the ground, so I'm ready for this. I'm
Okay.
locked and loaded. Let's go.
Okay, are you ready? Legit or bullshit?
Yep.
Okay. NSAIDs and rest for tendinopathy.
Bullshit.
Activator, the tool, not the method.
Bullshit.
Activator, the method.
Bullshit.
Toggling upper cervical misalignment.
Bullshit.
Oh, I love that one.
As soon as he said toggle, bro, he was like,
just lit up.
Not always necessarily adjusting a patient during an appointment.
Legit.
Gonstead X-ray line analysis.
Bullshit.
Technique doesn't matter. Lift how you want.
Bullshit. We're coming back to that one, though. We're coming back to that one.
Integrating chiropractic adjustments and exercise rehabilitation.
Legit.
Obviously. CrossFit.
Legit.
Chiropractors specifically advertising to parents, claiming they can help their kids' asthma, colic, bedwetting, cognitive emotional issues, etc. Yeah.
But I kind of want to come back to that one-ish, but bullshit.
Sitting is the new smoking.
Bullshit.
Ice for acute injuries.
Legit.
Cool, done. Not bad.
Okay. Which ones are we coming back to?
I think the technique one and the parent colic asthma one.
Okay, so lifting technique, I've got. I'm gonna shout out one of my really good friends, Yuji Suzuki. He's a chiro in the Portland area. He is a lot on the movement optimism, and he's. I love Yuji. Him and I get to have some great conversations. He's really big on that. It's and I think there's absolutely a place for it in exercise, in training, in rehab, gamification. Absolutely, make things fun, explore new positions. But especially depending on what your goal is, if we're powerlifting, you should be within a parameter. Now that parameter can be unique to your anatomy, right? If we got femur length, if we got torso length, the whole shebang, there should be a realm of relative consistency. But if we are deadlifting with your low back purely, that's not even a deadlift anymore. Now it's a Jefferson curl. So getting the nuances of that, should your, when you do an inline lunge or when you do a forward lunge, reverse lunge, does your, kneecap need to travel exactly over your second and third toe? No. But should it be, should you have complete knee valgus? Also no.
Yeah, totally. Obviously, it is strange that this has become so polarizing, isn't it? Because it's similar to what we talked about with the knee valgus. You could extrapolate that out to technique in terms of if you're an athlete, I think intuitively you're going to say technique matters. And the discussion will go, technique for performance matters. So most people agree with that. But we get into the weeds when we're saying technique is for injury prevention. That's where we get into the weeds, which I do still think it matters. But I'm obviously biased towards that side because I'm a powerlifter / ex-phys. So that's my thing. What you said when you were kind of advocating towards it not matter, the stuff you said on that makes sense, and I agree as well. Having fun, being able to play the sport, So I'm not necessarily against that. What I'm against, I suppose, is poor technique or posture under load. I think that's problematic. So when we get to the point where we're saying it's not, that can be dangerous for some people, in my opinion.
And like you said, for performance, we understand there are biomechanical advantages being in certain positions. Therefore, there is a better position to be in. Again, it just may matter on the individual.
Yeah, exactly right. And it would be interesting to say, when we look at these outliers in certain sports, like the morphology of a tall basketball player and how they're able to move into a little bit of knee valgus because it gives them a little bit more force production, etc. Just because a pro athlete does it doesn't necessarily mean it's the right way to do it. There's lots of things we've done in the past that have progressively changed. So it is an interesting discussion, especially with the knee valgus. Real funny one is when people argue against knee valgus in the squat, but they will use like female lifters to argue it. In my knee valgus narrative study, which has been peer-reviewed, I looked at 20 of the biggest and best squats in the world on YouTube. So I was able to look at the top 20 and I was able to plot a graph. And there's a very steep drop where valgus stops occurring. So you can say like this female person is the best and they're doing it. But when it comes to load, there is a consideration that must be taken for absolute load versus relative. And absolute load is predictive of a knee valgus at a point. It will shut it down. Female or male, once weight got to about 230, it shut down valgus. So you won't see, I squatted 400 kgs. And if I had my knees come in when I squatted 400 kgs, I'd be on the floor. Like, I'd be on the floor. And what people don't realize is they go, oh, powerlifting's not a combat sport. It's not stressful. It's pretty stressful. I was the first person to do it in my country. It's pretty stressful when you're putting yourself under an amount of weight that no one in history in your country has ever done. It is stressful. It is very stressful. And you see people hurt themselves.
Both contextual and like central.
Yeah, when you're under that weight, what it comes down to is, you're not going to let that migration of force immediately move in. And if you did under 400 kgs, I would have been on the floor. So yeah, it is interesting that absolute load seems to cut down valgus. Again, like I can't say that for sure, but I'm just saying like based on the observations, anyone can go and go on YouTube. I mean, you could think of the best squatters in the world that like the male heavyweights. You're not going to see any valgus. It doesn't exist. It can't exist. They can't get to that point.
Yeah.
Like you said, there are certain positions that you have to be in for force to migrate a certain way through our tissues and our structures. And if you deviate from that, it's not, you're going to land on the floor. So. And
then the last one was the asthma and etc.
Yeah. Yeah. What do you think?
So the only exception, and this is going to be a very, very like superficial level exception, is for like children with autism. I think building some sort of rapport with a doctor level provider or someone that they're going to see for care, and then especially with permission too. This is obviously that's the big portion when you're getting parental permission, but being able to get that permission from the child too is receiving hands-on care for children with autism. It's kind of building that medical system trust. So are they getting any additional benefit, other than like MSK benefit traditionally? Like, no. But I think being able to go to a provider that does work hands-on and the young child is being able to trust a provider, and then there's, still having to process, sensory input. I think there is some benefit there, but I wouldn't say, this is the end all be all, like, we're going to cure autism, because that's, that's not what we're trying to do. It's not what we're going to do. But there's being able to establish that, like, hey, this is a healthcare provider that we can trust, and they are, as long as you're respecting boundaries, helping you in some form or fashion.
Yeah, totally. I'd agree with that for sure. That is assuming that the chiropractor is a great guy like you guys, and not some piece of shit that's trying to like rip off kids. Trying to align their atlas to beat their ass.
None of the Y strap bullshit.
Anyway, I won't keep you any longer because it's probably what's it like 7:30?
It's 6:45 here, and I got 90 pounds here that's ready to rock and roll, and I think we got to fetch it.
There's Zeus. All right, well, hey, thank you for your time. Thank you for coming on the podcast. We appreciate it.
Absolutely. Thank you guys for having me.
Thank you.